So
Correct.
welcome to the webinar, Scan Path Strategy for Partially and Fully Edentulous Cases. The lecture is being presented by our very own Kelly Bevington, and we're going to begin shortly. And with that, it is my pleasure to introduce our Director of Intraoral Technology, Kelly Bevington. She began
Thanks
her
so much,
career.
Jessica. Go
She
ahead.
began her career more than 20 years ago as an RDA EFDA graduating from Bryman College. She has a comprehensive knowledge of dentistry and the dental laboratory industry. Kelly has been professionally trained on most major devices, and she is able to provide expert chairside coaching. She manages the NDX clinical iOS training team and has clinically trained over 1,000 dentists and their teams. Kelly enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. And now it is my honor to say, take it away, Kelly.
Thanks so much, Jessica. And truly thank Jessica for everything she does. We could not possibly manage all of this without her knowledge and expertise and technological guidance. So welcome everybody. As Jessica mentioned, please feel free to enter in any kind of questions you might have on the chat. I'm all about answering as we're going along. I also want you to know I have a Trios scanner and a Atero scanner here with me. So if there's something that isn't covered in the PowerPoint, we may just shift directly to one of the scanners if you have a particular question, or if it's a little easier to explain some of the new changes with software icons. So let's get started. I first want to present a disclosure that I am being compensated for this presentation as a full-time employee of NDX. And there are no particular financial interest or financial support by any manufacturer or vendors for this presentation. So let's review a little bit what our learning objectives were, why you're really here, something that caught your eye. We're going to define the 3 different types of digital dentures. I've got some samples here with me. How to most efficiently acquire patient data, and how to analyze the anatomy of the edentulous space and determine scanning strategies. So first, I'd like to explain a little bit about our iOS training team, which I manage. There are 3 of us that cover the US. I'm predominantly on the East. Brenda Kirkin, who is a CDA RDA, resides out of Michigan, and she covers the Midwest. And then we have Brittany Carey, who's a registered dental hygienist living in Arizona, and she covers the West. And just to give you some broad knowledge of National Dentex and our level of knowledge and expertise with receipt of digital scans, we receive over 3,500 intraoral scans from a multitude of different scanners. And looking at the slide, I can see where I need to add a couple new ones that have recently hit the market as well. I'm going to spend the majority of this evening specific to Itero and Trios, because that's where, as a laboratory, we receive the greatest amount of incoming scans specific to dentures and removable partial dentures. If there is a device that you have, or maybe that isn't even listed on here, that you're interested in learning more about, please feel free to reach out to me individually. I did put my cell phone in the chat, and a email and telephone number will be at the conclusion of the presentation as well. So I mentioned we're going to focus a little bit on Align Technologies Itero scanner, as well as 3Shape Trios. And it's the Trios 5 that I physically have here in my office. So let's talk a little bit about what a digital denture is and what those workflows might look like. So we define them as 3 separate entities, if you will. One is a copy denture, next is a reference denture, and last is an immediate denture. And I'm big on show and tell, right? So this is a denture, right? Just a regular old denture. And let's say the patient walks into your practice and they say, "Doctor, I absolutely love this denture. I'm going to be cruising this winter or visiting family in Florida over the winter, and I would like a backup. I would like a spare denture, an exact copy of what I have here." And so for that technique, we're going to, and I'll review how to scan, what that scan path strategy looks like. But we will scan this denture and the reposing, whether it be a denture or natural dentition, both on the cameo, the tooth surface, as well as the intaglio, the tissue surface. So that's what a copy denture is, an exact copy of what they already have. You could alter the shade of the tooth, but that's really about it. Reference denture. So the reference denture is what we see the most frequently received scans. And the reference denture is an existing denture that the patient has. And think of it as though we're going to use that existing denture as a custom tray, right? Think of it as a custom tray in your mind. And it might not be in great shape. It might have a tooth missing. It might have been fractured and glued back together. It is truly being considered as a custom tray. So this is an example of what we will do as a reference denture. And a reference denture, we're going to border mold with impression material. This is not a super great example of border molding, but we're going to border mold just like you would for a regular custom tray denture impression. Put it in the patient's mouth, let that set, remove it, then do a light body wash impression, put it in the patient's mouth, let that set. And when you do the heavy body in border molding, you're going to do your traditional phonetics, right? And muscle adjustments as well. And then the third, it's not really the last, the third item we're going to talk about is an immediate denture. So the immediate denture is really pretty straightforward. It is, as everyone knows, an immediate denture is a patient who has existing dentition that we are going to extract those teeth and insert a denture at that appointment, right? So for that patient, you are going to do full arch scans like you would for a removable partial denture or an orthodontic appliance or a bruxism appliance. The caveat with the immediate denture is making certain that you capture the buccal vestibular tissue, because that is going to be required, right, for the fabrication of the denture. And we'll go over some of those anatomical landmarks as well. So in most cases, the copy or reference denture as what can be done as a 3-appointment visit. So you're taking the scan, which is our final impression, inside this wash impression or the copy denture, right? So you're scanning this. So that's appointment number 1. What you receive back at appointment number 2 is a printed functional try-in. So this is printed material. It's the denture material that we're using is Dentsply Lucitone print, and the functional try-in is a monoblock of that material. So you are able to even send your patient home with this try-in, and they can try it out for a couple days. Most patients don't typically show their gingiva as a denture patient, when they're speaking and smiling. So you need to take that into consideration for that particular patient or not. So copy denture and reference denture would receive the printed functional try-in. You could use a traditional wax try-in also, if that's a workflow that you're interested in doing. Some people want to be very hands-on with the movement of the denture teeth during that try-in process. Some patients want very natural looking setup to their teeth. So the dentist ability to move that in the operatory chair side, it can be very beneficial to creating a very natural setup. Other patients and dentists are not as concerned about being that hands-on with the setup itself. And in that case, you would request the functional try-in. The functional try-in can still be altered. You can take a burr and adjust the occlusion. You can take a Sharpie marker and identify to the laboratory to shift a midline, a couple millimeters left or right. You can rotate a lateral. You can build out the buccal corridor. So there are some adjustments that can still be done with the functional try-in. And then the immediate denture really is a 2 appointment. You are going to scan, and then at the next appointment, you will be extracting the patient's teeth and inserting that denture. And typically that's referred to as a healing denture, a temporary denture, if you will. And you will do another one, a final, perhaps 6 months later. So using the 3D printed workflow provides a really nice sort of seamless integration, and it can potentially eliminate a try-in altogether. I'm not personally at the point where I'm ready to encourage people to forego the try-in, but we do have many customers who have done the functional try-in with such great success and have created a really good workflow for themselves with that they are now bypassing that try-in altogether. Might be something that I can get more behind in the future, but at this moment in time, not quite yet on that. I do have a question that popped up. Are you seeing less retention scanning tissue versus scanning an alginate? So really good question, and quite possibly so. So the reason why we're discussing tonight either the copy denture or the reference denture versus scanning the intraoral cavity is because of the concern of lesser retention. And let me explain that a little bit. So I'm going to keep going with the reference denture for just a moment. Just know that it takes a little bit of time. I would not say 15 minutes, but you do want to make certain that you apply a tray adhesive inside on the intaglio of the denture and letting it dry or air drying it prior to taking that impression. And the true benefit, in my opinion, the true benefit of the reference denture workflow is for the patient, because at the end of the appointment, after you've scanned this denture that has the wash impression inside of it, you're going to peel that impression out and hand the patient back their denture. So they're never without teeth. Otherwise, you would, like with a reline, for instance, they're going to be without their teeth altogether. So that's a value add for the patient experience themselves. And so these are some clinical assessment photos of a well-worn denture, but still very good to take the reference denture scans on. Again, the occlusion is going to be worn, but they're still intact. Again, if one of the denture teeth had potentially popped out, it would still be serviceable for the reference denture technique and scan. And you do want to make sure that any reline material or any tartar that might be on the denture is removed prior to doing that wash impression. And I like this, how, we're talking about that the borders are well extended and that the base covers the retromolar pad. Really important that we're covering and acquiring all of the anatomical landmarks. So let's talk a little bit before I go further with this to address your question, I think, statement about scanning the fully edentulous intraoral cavity. So the intraoral cavity can be scanned, and it can be scanned very well in my experience on most all of the scanners out there. There are particular workflows on each scanner's RX, on the digital RX, that you do need to pay attention to and select removable, select, tissue supported denture, or with trios, and I will show an example of this. When doing the wash impression, for instance, you're going to select impression, although you're scanning a denture. If you select the icon to scan a denture, that's really for the copy denture. But what we experience is over retracting of the lips and cheeks. So one, I implore you to utilize four-handed dentistry, right? It's either the assistant is assisting the dentist, or perhaps it's two assistants working with the patient. But when you're retracting the lips and cheeks, you're going to most probably utilize some sort of ancillary item. It could be a plastic mirror. We want to avoid metal because of light reflection. You could utilize a tongue depressor. Tongue depressors work really well. There are little gadgets out there available in the industry now. This is called a ScanMate, and it is flexible, it's anti-reflective, it's autoclavable, so it's reusable, and it's very kind and gentle to those vestibular tissues. So what can potentially happen is you are over retracting the lips and cheeks, you're capturing the scan, but when you get your denture back, and it could be a functional try-in or a wax try-in, that there's no retention. And the reason there's no retention is a denture receives its part of its retention when the lips and cheeks are at rest, right? So if the lips and cheeks are too overextended, over retracted, when you're scanning, it's not going to be the same fit as when the denture is being worn and they're at rest. So that's why I like the reference denture technique instead of scanning the patient intraorally. But there's approximately 20% of your patients who come in for a denture and they don't have an existing denture. So we need to be able to accommodate those folks as well, right? So you are going to scan to the best of your capabilities. You're going to make sure that you capture the buccal vestibular tissues, the full palate, the hamular notch, the vibrating line. That's all critically important. The same anatomical landmarks that you capture with a physical impression need to be captured with a digital impression. But let's say you're not successful with that, and the laboratory calls and says, "Oh, we're 3 millimeters off from the vibrating line. That's going to be really important. There wasn't a optimal capture of vertical. Maybe the patient didn't have any opposing dentition, nor do they want any opposing prostheses created. What the laboratory could do is could create you a custom base plate, right, with a wax pipe block. And in my opinion, this is a wonderful alternative, right? So your initial scan, think of it as an alginate. What you're going to get back is a custom base plate with a bite block. You can take the wash, border mold this, place it in the patient's mouth, do your phonetics, right? Then take the light body wash inside of this, place it back in the patient's mouth, let that set, then take care of vertical, right? Then you're going to validate the vertical dimension. So you could take a hot instrument and melt this wax as needed, or build it up further if you would need to do that as well. So that sort of addresses the question about less retention. Any advice on scanning the edentulous mandible? Always cross my fingers a little bit. It really depends on the patient. It really does. And if you have two people assisting with the scan. So in some cases, the ridge is so far resorbed that the tissues lingual of the ridge under the tongue are actually sort of floating over top of the ridge. So you need to be able to move that tissue to capture the ridge. And in a case like that, I would very much ask for, I would still take the scan. Hopefully you could get the retromolar pads, even more so than like the lingual flanges, for instance. But if you then received back a custom base plate with the bite block, that allows you to take the impression, right, for the lower, and it's the pressure of you holding the tray in place that displaces those tissues. So the tissue needs to be displaced in one way or the other, either physically with impression material or physically with a mirror, a tongue depressor, or a little device like ScanMe. See, another question came up. Especially for patients with flat ridges, yeah. Yeah. Again, it's displacing the tissue. You need to be able to displace the tissue in one way or the other in order to capture the ridge that is still there. Okay, let's continue with our workflow with some different images than my little demonstration guy here. So again, this is a reference denture. This is border molding with the heavy body impression material. And notice we've got the blade, a scalpel, a Bard Parker up here. So you will see some excess material when you do this technique. And I wish I would have had a scalpel with me when I did this workshop, but I did not. And now I'm afraid to try to cut it, that I don't have impression material with me to redo it. But it scans much, much better if that buccal contour is smooth instead of the lump, the overflow of the actual impression material. This is identifying that it's important to apply tray adhesive to the intaglio of the denture before you start your border molding process. And you want to make sure that it's dry. I've done it a couple times where, you know, we're all a little impatient, and it can take a little while for the tray adhesive to dry, and it was still a little tacky, and it just made it a little messy. So use some air to help dry that. Here you see it being applied. and then the bite registration, right? So the bite registration, and this is for an upper and lower case, of course, the bite registration is super important. And what I recommend to people the lighter green was the heavy body border molded. The teal or aqua color is the light body wash impression material that we did. And then the purple is more like a blue mousse bite registration material. And this is a bit much, but I do like to put a little bit of blue mousse or a more rigid bite material as the patient is closing. And it's important to verify, like, what their quote unquote normal occlusion is before you start this process. Because when you get to the bite registration portion, you're going to put a little bit of material on the occlusal surface of the lower denture and then have the patient bite into place. Otherwise, the patients with denture tend to slide. Their dentures just slide in general. And it's really, you want them to slide and then let the material set and then take a bilateral bite registration. So with all of the scanner system, I say all, there might be one out there that does not require a bilateral bite, but for the great majority for all the scanners I've worked with, and that's probably about 10 across the board, a bilateral bite is required when scanning full arches or full dentures for new prostheses. Do you scan the denture pickup impression into the impressions? We can send you information on ScanMate. Henry Shine and Patterson, I know, was a distributor for ScanMate, but I can double check that for you. Do you scan the denture pickup impression into the impression setting? On Trios, yes. So the answer to that is on the Trios device, yes. So a couple helpful tips. I don't like to use the word tricks. People will say tips and tricks. So it's like, oh, I don't want to trick you. It's like trick or treat, right? I guess it's a trick. It's a good thing. But moisture, saliva, blood, hemorrhaging are not our friends when it comes to intraoral scanning. And I think we all know that when scanning for crowns, right? Like that's just sort of a given. When it comes to scanning for dentures, it's also really important to take like a 2x2 gauze or a 4x4 gauze. Make sure that if you're doing like this copy denture, make sure that you're wiping out the inside of the denture as well as the cameo, right? Like that, so there's no little saliva bubbles on the occlusal surface of the denture. And let me tell you, if you've not done this before, when you're wearing gloves and you pick up a wet denture, whoo, they are slippery. So hang on to them tightly. And I'm right hand dominant. So I hold the denture in my left hand, and then I will move the wand with my right hand, with my dominant hand. Okay. Try to keep the denture as still as possible, and you will have greater success with that. So keeping it stable. Some people will ask me, well, what about putting it on a tabletop, on the counter at your office? And I have not had success with that. And I've tried to put like sticky tack and things to keep the denture from moving, but it still wants to slide away from me. So I haven't had great success with that. But keep it dry and free of any kind of tartar or, glue, reline material, things like that. You want to make sure that it's clean of that. And then when scanning intraorally, let me go back a second. When scanning intraorally, also, you want to make sure that you take like a 2x2 gauze and wipe off the gingival tissue well before starting to scan. Now, typically, in my experience, the more geriatric patient, sort of myself included, once we start to lose the elasticity in our lips and cheeks, it's actually easier in my experience to scan those patients. It's the patients that have the real tight lips or very heavy cheeks can be a little more challenging to scan. And sometimes we need to walk them through the process as to what we're doing next. And to be very, very honest, when I explain to a patient, I ask them if they've ever had an impression taken before. If they had an existing denture, I bring the obvious, I'll say something like, well, I'm certain that you had a physical impression taken before when you had your original denture made. Today, we're not going to do that same process. We're going to take some pictures of your mouth with the scanner camera, and then I show them the camera. Most of the patients are thrilled. They're like so excited that they're not going to have a traditional physical analog impression taken. So that's usually a very positive thing. The other thing I'll share with you that when scanning the fully edentulous intraoral cavity, especially on the maxilla, there's this little guy. It is called a Dr. Thompson stick. And a Dr. Thompson stick, let's take one out here, has like an indelible ink. Let me see, like an indelible ink on it. So you moisten the tip of the stick, and then you can use it intraorally. And typically what I will do is on the intraoral cavity, I'll start at the rugae and I might make like a little Christmas tree sort of going back and forth, or a few X's, especially where the vibrating line is. And the reason I do that, it's not for the scanner necessarily. Like iTero, for instance, scans strictly off of topography. So the color of that Dr. Thompson stick ink doesn't have anything to do with the accuracy of the camera's acquisition at all. All it does is it creates a pattern for Kelly's eyes and Kelly's brain to follow while I'm scanning intraorally. Sometimes when you're scanning the maxilla intraorally, all that pink gingival tissue starts to look very similar, especially if the patient has been wearing a denture for a good amount of time. Their rugae usually isn't really present, with lumps and bumps and grooves, and it can be difficult to follow a pattern. So that's why I like to use the little Dr. Thompson sticks. Patients that have had recent extractions, oh my gosh, they're like the easiest people to scan because they have all the lumps and bumps and grooves that the scanners all pick up very, very quickly and very accurately. So let's talk a little bit about those anatomical landmarks. This would be if we were going to do an immediate denture. So you want to make sure that you are capturing the vibrating line, right back here. You want to make sure that you're capturing the hamular notch on the maxilla. You want to make sure that you're capturing the buccal vestibular muscles in frenum. And then on the lower, you want to make sure that you have your retromolar pad. And don't forget about the lingual data, right? I mean, that's really important, and that's can be challenging to capture, challenging to acquire. If the floor of the mouth is sort of puffing up over the ridge, if the patient has less dentition than this. And that's just an example of a complete bite registration on that patient. That's an example of a reference denture. We did that one with a prime scan. And I wanted to show you what we at the laboratory, we also use 3Shape as our design software for the digital denture. So that's just an image of one of the try-ins set for the digital denture. This is an example of the functional try-in. So it's a maxillary and mandibular functional try-in. This particular case, the patient was sent home for 2 days and they experienced the denture. The maxillary denture was fantastic. There was no need to make any adjustments. On the lower, they felt there could be additional retention. I'm not surprised because that initial impression was just a scan, right? There was nothing to displace the tissues. So we did a wash impression on the mandibular functional try-in and then set the bite. Now, at this stage, you could potentially scan it, but I really wouldn't. I would take what you have right there, package it well, and ship it to the lab. I use the language digitally assisted a lot right now. If you're familiar with scanning at all, and I've been scanning for approximately 18 years, I figured it out the other day. I was like, wow, it's hard to believe that intraoral scanning has existed that long. Huge evolution in the technology in the last 12 to 18 months, just like rapid changes, which is really exciting. And that's part of why we do programs like this, because it is ever changing. But the need to scan everything all the time, like this, for instance, I would put it in a box and send it to the lab. The lab has a desktop scanner that will scan that 3-dimensionally. The same thing as if you ended up with the custom bite block and take the wash impression inside of it and verify vertical so that you have an opposing as well. I would put that in a box and ship it to the lab and let them scan the whole thing 360 degrees, and it'll go directly into the 3Shape design software. Question here. Is there a material you recommend for functional impression that a patient could wear for a few days? Well, this is, it's a printed monoblock through Dentsply Sirona. And I believe it is part of the DLP, Digital Lucitone Print family. But it is the temporary denture monoblock material. Great questions. And we do print our dentures and our try-ins versus milled. That's an important difference for people to understand. Most labs that I have interacted with, they choose one or the other. Often they don't do both. And there are some labs out there that preferred a milled denture product. And at National Dentex, we have opted to go with a printed solution. Now, the functional try-in, it is a monoblock material. It's all one piece. All right. So the teeth are not separate. It's all one piece. And in these images, you can see where the occlusion was checked, right, and adjusted. The midline was shifted a little bit here. This is indicating to bring out the buccal corridor. And this is bringing the one lateral out a little bit as well. And that is an immediate denture scan. Question. How are you repairing fully printed dentures? That's a really lovely question, because what we're experiencing is that there really isn't a need to repair them. We're not experiencing like a denture tooth popping off. You won't experience that because it is printed. So the gingival tissue is printed separately than the teeth, and then they're chemically bonded together. And again, it's Dentsply Lucitone print. Dentsply has been in the denture business longer than I've been involved in dentistry. I think it's 75 years, 100 years now. But I'm happy that we went with a manufacturer vendor that's sort of tried and true within that industry. So we're not experiencing repairs yet. With cases on a lower mandibular ridge, as I pointed out, do you recommend, whoop, sorry, it jumped on me. Do you recommend to have a soft acrylic instead of traditional hard material be used on the ridges? For the final, I think that's Dr. Spivak. I'm not sure if you're referencing the soft acrylic on as the final denture. I know IvoCap, an Ivoclar product, used to have flexible flanges on mandibular dentures. I don't believe that is still a product out there. But I could double check that. What color of wash impression material do you recommend when doing it would be a reference denture. So we wouldn't use impression material on a copy, only on a reference. I tried it once and it took me hours. Oh, I'm sorry. To scan it well enough. Yeah, 1.5 years ago is going to be right about the time when iTero came out with a new RX and workflow, which I've got right here in front of me. So it may have been before that. And the trick was knowing when to turn AI on or off, Dr. Murray. That was the big deal. So originally AI was created on all these systems to eliminate our fingers, the patient's tongue, the inside of the lips, the cheeks, and it took a while, but it worked great. It worked great. We were no longer having to cut away and trim lips and cheeks and tongue. So that was fabulous. And then, it's supply and demand. So then dentistry demanded that the scanners also be able to scan for removables. The problem is when it's tissue and it's not dentition, AI, although smart, wasn't quite smart enough yet. It would keep cutting away the tissue. And I'm sure that's part of what you experienced in trying to scan the inside of a denture. So mine is yellow and pink. I don't necessarily recommend yellow and pink. I have used blues and greens as far as a color, and it seems to pick up faster. It seems to pick up and stitch together better. Now, again, iTero's, research and development says color is not an issue with iTero, that it's topography. It's the lumps and bumps. So, it's patient specific as well. And then, yes, soft on the final. So the soft flanges, I think is what you're talking about. I have my note here. I'm going to see if IvoCap is still available or what we might have that would be similar to that. And so it was actually like it almost had a hinge on the flange and was similar to the flange being coated with a soft reline material. I think that's what you mean by soft acrylic. So, okay, so we're going to talk about the iTero RX and workflow, and then let me take a look at my time. We'll move into the trios as well. So with the iTero new workflow, you're going to put in the patient's name, their date of birth, laboratory, all that kind of good stuff. But what I want you to pay attention to here is selecting the procedure is under denture removable. Okay, so the procedure is denture removable that you want to select. And then under the type, you are going to have a choice. And your choice is going to be a partial, an immediate partial, an immediate denture, implant supported denture, or tissue supported denture. So selecting that correctly is going to be really important. And then under the stage, in most cases, you're going to ask for a try-in, would be my guess. In some cases, the dental laboratory may call you and say, hey, we're going to recommend a bite rim to allow you to take a wash impression inside of this bite block, right? And to verify vertical. So it works sort of twofold. And then, of course, you're going to be able to select the mold of your denture tooth and the shade of your denture tooth, as well as the shade of your gingival tissue. This is an example, and this has been around forever as far as selecting a mold for a patient that does not have an existing denture, and it is mirroring the shape of their face. Others will say to take the shape of your face and invert it, and that is also a good tool to use for selecting a tooth shape. Super. So this is some scan path strategies specific to iTero. And it is scanning the occlusal surface of the cameo first, and you're going to follow the path of all of the occlusal surfaces first. Then you're going to do the inside of the palate, wrapping over to the borders, right? So wrapping over to the borders. And when you're capturing the borders, as in the picture, you want to capture some of the border and then come down to the buccal incisal cusp, come back up to the border, back to the cusp. And it's very smooth. It's smooth and steady. It's not an abrupt twist. That's the most difficult thing I think I have explaining to people, is it's a smooth, steady process. Then you are going to take, that's a little heavy from here. Okay. So then you're going to take the scanner head and wrap it over, right? Wrap it over to the intaglio and take the wand and turn it off. And that's going to allow the processing to occur a little bit. Then you're going to start up again right where you left off. If you're a user of iTero, you know that it needs to see something it has previously scanned to begin stitching that virtual model together. And then last is going to be to capture vertical. And I will share with you the lab technicians at NDX really don't like this slide. They don't like putty bites in general, but it's really, very much guessing what the patient's vertical might be. But for that fully edentulous patient, If you want to try to go directly into a try-in, it can be a good option. Notice how the putty, though, is scored. It's marked. That's going to be helpful to you when, so it's not just a color, it's not just a Sharpie, but it's actually physically scored. When you go to take your bite registration, your bilateral scan, you want to make sure that you're picking up those scores as well. And then that's an image with the functional try-in in place. And just a maxillary denture scan. And that's of my particular denture that I have here. Okay. When we talk about immediates, it's still going back to keeping the intraoral cavity dry, right? Using something to stabilize the tissue, especially on the mandible that we've already discussed. And if with iTero, for instance, the head of the wand needs to touch the tooth surfaces or the gingival tissue surfaces really at all times. So the lens has a tendency to get smeared when you're scanning the edentulous patient. So be prepared with some cotton rolls, some 2x2s, maybe even an alcohol pre-moistened wipe that allows you to quickly and easily remove any debris from the wand itself, from the sleeve. Are you scanning the bite in the mouth? Yes, yes, I am scanning the bite in the mouth. That's an intraoral scan. And then we'll do a little bit of the lower. So in the lower, we're going to start at the midline and start at the frenum. And we're going to do one side and then the other. And anytime I'm doing lefts and rights, I've created a habit for myself that I always start on the right-hand side. And then when I'm scanning my bite registration, I'm also starting my bite registration on the right-hand side. And I think it provides you a little better merging of data, especially for that bite registration. And somebody asked about slides. We are providing physical handouts that are specific to the iTero and to the Trios as well. And this is all in your handouts, right? So it's capturing the palate, it's capturing the ridge, it's capturing the buccal vestibular muscles, and then our bite registration again. So let's go through Trios a little bit. So Trios also splits the mandible separately, right? And I would like to do something here. I know we're right at the top of the hour. So I'm going to go through this, and then anyone that wants to stay on for another 5 or 10 minutes, I want to be respectful of everyone's time. If they would like to stay on, I am going to stop sharing the PowerPoint and shift to sharing my Trios screen and show you the specific icons there, right? This is part of a handout that you will receive. And my best recommendations is to go slowly, slow and steady. Here's an example I wanted you to see of inappropriate scans, right? Scans that were not acceptable. They were not good enough for the laboratory to fabricate the immediate denture and a removable partial denture. Okay, we've got some great resources that are part of your handouts as well, and some resources that I have utilized to put together this presentation are the iTero and Trios websites. And then this is an upcoming presentation that we have specific to iTero. And let me check this. Do we have handouts? I'm not sure if they were already sent or if they are being emailed after the presentation for those of you who
They
attended.
were, hi Kelly, it's Jessica.
Hi.
They
Hey,
were
Jess.
already sent about 3 hours ago, three and a half hours ago in your email boxes. Could have been blocked by spam. It came from our NDX education at nationaldentex.com. But I'm trying to quickly copy and paste all of them in right
Oh
now.
my gosh, you're a dear. Okay, and I'm reigniting my trios there. Okay, and you can scan this QR code if you're interested in registering for the upcoming program on October 30th. That's going to be specific to removable protocols, including overdentures and implant supported dentures. Oh, I love the thumbs up to you guys too. Thank you for being here. And thank you from us. And I'm going to stop my share. Okay. Let me check my chat and then I'm going to go to the trios. Was there another question? Or is that you,
No,
Jessica?
there wasn't. It's just me right now.
Okay. Okay.
It'll flash one more time. I'm just pulling up the last one to attach.
Awesome. Thank you so much for doing that.
Absolutely.
Oh, shoot. I connected before we started and it timed out. So bear with me 1 second. So we have the capability at National Dentex to support you remotely. And what that means is we can remotely access your scanner and go through assessment of scans if you'd like. We can do a demonstration. And what I'm doing right now is remotely accessing my own scanner. So I can show you something special with the software.
In the meantime, to touch base, we will be having Kelly again featured October 30th, Digital Denture Protocols, Procedures, and Practice Implementations. And I will post up that information in the chat as well as the flyer. And then coming up is one of Kelly's clinical trainers in the Midwest region. On the 10th, Brenda Kirkin will be presenting clear aligner therapy, protocols, procedures, and practice applications. I didn't get that one out in advance for Kelly to have it on her PowerPoint. But I will be posting it out to you all in chat here.
Now you can see my screen, right?
Yes, we can see
You can
your
see the trios.
screen. And to answer a couple questions really quick,
Yep.
Kelly and I, it says, what NDX lab are you with? We are with corporate. So
We're with them all.
network. And then do you support all types of scanners? Yes, we do, but I'll leave that to Kelly to go in depth.
Yeah, we do support all types of scanners. So as the different laboratories, and there's approximately 60 of us across the country, 60 different labs, have the capabilities of receiving STL files from anybody, right? And making a direct connection with any scanner that has direct connection capabilities versus just sending STL files. As far as myself and my team supporting you, we readily support iTero, Trios, PrimeScan, Medit, Dexis, Plan Mecca, a little bit with 3Disc, getting on board with Atomica. I mean, there's more every day. So, and it's really by demand, right? What our customers are looking for. And we become certified with the different scanner manufacturers. So if there's a particular one of interest, let me know so that we can learn more about it to better support your needs. So this is the prescription for Trios, right? And I want to go to removable. And I'm going to select full denture. And I'm going to tap on a tooth on the image of the denture. And did you see here how now it outlines in gray? So that indicates that you have selected a maxillary denture for your prostheses. Now it's going to ask for what type of material. I'm going to state printed. I'm going to save. And now I'm going to turn my scanner on. Thinking about it. Scanner's now ready.
We apologize for the delay. We had a funny feeling this would happen. With security protocols, every platform logs you out if
Yeah.
you go idle. So that's what we're encompassing right now. So it just gets a little tricky when.
Here we go.
Oh, there
This is
she
the
goes.
magic screen. This is the magic screen. This is really, really, really what I want to show you. So let's take a look at this for those Trios people that have stayed on. Sorry, my wheel does not want to wheel there. Okay, the edentulous truly is that. That is the fully edentulous patient intraorally. Okay, existing teeth, that is going to be for an immediate denture. So your patient has some existing dentition and you will be using those teeth as a reference, but you're also going to be capturing your anatomical landmarks, your buccal vestibular muscles, your post palatine vibrating line, your post palatine seal area. Reference denture. Reference denture is this guy, right? This is the patient who has the existing denture, but it's not adequate anymore, and you're using it as a custom tray. And you're going to scan first the cameo portion of the denture and then the intaglio part of the denture. The copy denture, I didn't really want to touch it. Is that exactly? It is a copy denture. Can I go back one? And then the last one was a picture of a custom tray. And that would be if you had an impression of a custom tray. Any questions on that? I saw a bunch of questions, but I think it's you. Yeah. Super.
We do have two people that have raised their hands. Kelly, is this
Yeah.
a good time to shout out?
Yeah, absolutely.
Dr. Ford, I'm pushing allowed to talk. You
Okay.
would have to unmute on your end, and I'm pushing unmute on Dr. Martinez. Dr. Ing Ford.
Hi,
Oh,
this is Dr. Ford. Thank you. My question was already answered. Thank you.
thank you.
You're welcome.
And Dr. Martinez, Kelly Martinez.
Did you have a question, Dr. Martinez?
Probably an accidental raise of hand.
Okay.
So I'll file them back. Thank you both.
Of course.
For utilizing all the features, as you can tell. We will go there and when the time is right, be able to allow you to come on live if you want that interaction with Kelly. And then also, don't forget, Kelly will be sending the information out. But our iOS team is there for you, as she has mentioned, whether it be phone, email, live, virtual. So feel free to reach out.
Absolutely. Absolutely. And if there aren't any other questions or need for a demonstration scan, I am going to give you the rest of your evening back. And thank you for spending your time with us.